So now that we kind of have some idea about the T cells and the B cells, let's talk specifically about the immunoglobulins. And I like having this organized in this way because remember, in the last video, when we had defects with the BTK gene in Bruton's A-gamma globulinemia, we had pretty much wiped out all of our immunoglobulins. And we also saw that in combined variable immunodeficiency, where we had defective B cell development, and we just wiped out all of our immunoglobulins. But here, the difference is we're not wiping out everything in a lot of these cases. We're just focusing on one or two immunoglobulins that are going to call our attention to this specific disease. So we have to be able to kind of distinguish these. Remember, if we have a global phenomena of immunoglobulins being very low, we are going to start to think more so about the B cells being involved, as that's going to be upstream from this whole process if we go back to the diagram on the last video. But let's focus on these immunoglobulins here. Let's start with IgA. So the big IgA pathology here is going to be selective IgA deficiency. And this is going to come up very classically in board questions when they try to transfuse a patient. They start to transfuse the patient, and all of a sudden the patient goes into anaphylactic shock, and they're thinking, well, what's going on? We just gave this patient some blood. Why are they kind of having this kind of reaction? And the idea here is these patients will have very low levels of IgA in the blood. And the reason they might have those low levels of IgA in the blood is because they have antibodies essentially against the IgA. And so if you go back to talking about your type 1 hypersensitivities here and talking about IgE, let's just say that I have some mast cell or some basophil here. We'll just say it's a mast cell. And again, my patient might have antibodies against their own IgA. Okay, and so if that's the case, then we're marking our own IgA for destruction. So this patient might have very low levels of IgA. Maybe our body destroyed all of the IgA because we have antibodies against it. Some of those antibodies might be an IgE antibody against IgA. So let's go back to kind of the basics here for a second and just explain what's going on. So let's just say, we have some mast cell, and remember, we also have IgE antibodies in our blood, right? So IgE antibodies, and we talked about, having like an anaphylactic reaction. So here's my IgE antibody. I have an FC portion that's kind of docked up against that mast cell, and then I have a Fab portion out here, and that Fab portion is essentially binding to an antigen. So let's just say there's some, something we're allergic to. It could be, maybe it's an antigen from a bee sting or from a drug that we took, potentially that, that we have an allergy to, or maybe it's even something like peanuts, for example, right? Or it's something, a shellfish. And anyway, the point is that antigen binds to this Fab portion and can cause cross-linking of the IgE here with other IgEs that are on the mast cell. And the big thing that we have to remember here is that these mast cells, in response to the binding of this antigen, they can degranulate. So they can drop all of the granules out into the blood, and this process can set off a very strong immunoresponse, particularly using things like histamine, right? And then this can cause anaphylaxis, right? Anaphylactic shock from this massive widespread vasodilation. What's different here is that instead of this antigen here causing this whole problem, maybe, like we said, it's something this patient's allergic to. Instead of this antigen here, the thing that's causing these mast cells to degranulate is actually going to be an IgA antibody. If this patient's given blood that has IgA antibodies in it, this IgA antibody will bind to this IgE antibody in the host, and that binding will cause degranulation of the mast cell. So that's why we say that this patient here, the host that's receiving the blood, has anti-IgA IgE. Now read this carefully. Anti-IgA. This antibody is anti-IgA. It's against IgA. It's an anti-IgA antibody. And what type of antibody is it? It's IgE. So it's an anti-IgA IgE antibody, okay? And again, these patients are essentially allergic to IgA antibodies. So that's why it's called selective IgA deficiency. So again, if you have a board question, they transfuse a patient, they go into anaphylactic shock. There's a lot of different transfusion reactions. This is the classic one that you want to think about in that scenario. When you have an immediate reaction. Now that's pretty severe, but if we're just talking about, illnesses that can come from this, the illnesses in and of themselves are not so severe, okay? The anaphylaxis obviously is very severe if we transfuse this patient blood with IgA antibodies, but in general, just from an infection perspective, remember IgA is primarily going to be in the mucosal lining. So whenever you see IgA, you could develop respiratory illnesses, diarrhea. The classic thing to remember though is giardia. When you have IgA deficiency, test writers love to ask about giardia because IgA is very involved with preventing infections, or at least fighting infections with giardia. The other thing that you can sometimes see here is celiac disease being very classically associated with IgA deficiency. Now remember, this is again where this gets tricky, where you want to know your isotypes. Sometimes when you test for celiac disease, there's different types of tissue transglutaminase antibodies. Okay, so this is the tissue transglutaminase. Okay, so when you suspect a patient has IgA, sometimes you test them for this antibody. Now, there's different types of the antibody you can test for. If you test a patient, right, a patient that has selective IgA deficiency, which is very much associated with celiac disease, if you test them for celiac disease using a tissue transglutaminase IgA antibody, well, guess what? That might come back negative, but maybe this patient actually has celiac disease. And the reason for that, remember, if this patient doesn't make IgA antibodies, right, they don't have any IgA antibodies, they're not going to have an IgA variant of tissue transglutaminase, right? It's going to come back negative no matter what, whether they have celiac disease or not. Okay, so that's going to be a false negative because that patient, we might think that they might not have tissue transglutaminase IgA antibodies because they don't have celiac disease, but in reality they do have it. They just don't have IgA because they also have selective IgA deficiency, which is very much associated with celiac disease. So just something to keep in mind. Now, in terms of the diagnostics here, again, of course, the big point is serum IgA is going to be low. Should your other antibodies be low? No, right? This is going to help you differentiate this from some of the other B cell disorders. Remember, if I knock out B cells, I'm going to essentially knock out all of my immunoglobulins like we talked about in the last video. But here, the other immunoglobulins are just fine. We're really just talking about IgA.